Hello, good morning everyone. Today I'm presenting on adductor related groin pain, so as known as sports hernia lah. So in Doha Agreement in 2015, they confirmed the approach to the classification of groin related groin pain into four entities lah. So they divided into iliopsoas related groin pain, adductor related groin pain, pubic related groin pain, and also inguinal related groin pain. So sports hernia is actually characterized by anterior pelvic pain occur as a result of adductor muscle injury due to direct trauma or overuse microtrauma. So the epidemiology and also prevalence of the adductor related groin pain actually is common in sports that involve a lot of kicking, a lot of twisting, turning, sudden deceleration and also acceleration, and also changes in direction. For example, soccer, football courts, and also ice hockey. And also it's more predominant in male compared to female. The risks that can be associated with adductor related groin pain includes the decrease in your adductor muscle strength, reduce in the sport specific training, history of previous groin injury or groin pain, and also higher level of play for athletes. Anatomy wise, hip adductors is actually composed of gracilis, pectineus, and also three adductor muscle, adductor longus, brevis, and also magnus. Among these muscles, adductor groups are the mostly injured muscle, and adductor longus is the mostly injured adductor muscle among the three adductors. So the insertion of the adductors is actually from at the medial 1/3 of the linea aspera of the femur, and the origin is somewhat a bit special for the adductor muscle. It composed of 60% of muscle, and it runs across in front to the pubic symphysis, and also later it fused with the external oblique muscle and also obturate external oblique muscle and also rectus muscle, forming an aponeurosis. The aponeurosis later will attach to the pubic symphysis joint. So the presentation for adductor related groin pain is classically patient will come with the pain at the medial groin, which is the insertion side of the adductor longus at the pubic bone, and also it can radiate medially to the medial thigh, and the patient will always tell that the pain is aggravated or it's often associated with kicking, with side to side movement, and also twisting and turning or during the exercise. So on examination for the adductor related groin pain, is basically there is a localized tenderness over the adductor muscle, pain upon resisted adductor, and also pain and also the feeling of tightness upon adductor stretching. Differentials for adductor related groin pain, as we base on the Doha classification, it could be from the pubic structures, inguinal canal structures, hip related groin pain, and also other pathology, for example the surgical hernia, referred pain from the lumbar area or the SI joint, and somehow can be because of nerve entrapment, the obturator nerve entrapment. Diagnosis is often made clinically, but other imaging modalities may be needed to rule out other pathology. For example, X-ray is quite beneficial for us to rule out any stress fracture of the acetabula, and to assess the pubic symphysis. Probably there's a widening of the pubic symphysis, there's a sclerosis or osteolytic changes. Ultrasound is what we usually use in our clinical setting because we can see an evidence of any tear or intrasubstance tear or any edema. And MRI is basically can be done, but it is very sensitive. It can pick up all the abnormality, but it has got no clinical relevance that helps the doctors in diagnosing the pathology. So Common finding in MRI could include bone marrow edema, changes in the adductor tendon insertion sites. So for the treatment, basically as what has been introduced by Prof. Holmick he published in the Lancet in 1999. Treatment for adductor-related groin injury is the basis of treatment is exercise therapy. So he postulated an exercise regime, 2 modules. The first module is specific dynamic and isometric exercise to reactivate back the adductor muscle. The second module is the resistance training as well as the balance and also coordination exercise. So between these modules, he recommended, of course this has been revised and updated from time to time, but from his module, he recommended the exercise to be done alternated for 3 times in a week for a period of 6 to 12 weeks duration. And then he recommended also no stretching of adductor during the 2nd to the 3rd month of exercise therapy. There is injection of steroid, but it's actually not recommended because there's no evidence on the long-term beneficial effect for adductor-related groin pain. Adductor tenotomy, there is a surgical approach for adductor-related groin pain that includes adductor tenotomy, but is extremely and rarely indicated. Other modalities actually oral NSAIDs, painkiller, and compression shorts. For example, for those athletes who has still having symptoms but they have to undergo training and also playing in the game, so they can apply on the compression shorts. And also manual therapy, although actually not really helping, but some reported a bit of improvement in the pain. That includes adductor muscle manipulation, adductor stretching, and also graded running program. Okay, that's all for today.